Okay, guys, I am back recording again. This is one day after my illness from the previous module recording. And look, my cell phone's already going off again. All right, maybe at some point this semester I'll be able to get it together with recording these lectures. But today we are going to be starting our arterial information. We do have a couple modules worth of material for this aspect of the cardiovascular system. Venous was a little bit of a review. I know arms are probably feeling a little bit foreign to you guys, but we will continue to scan venous arms while we're still kind of learning about arterial anatomy and evaluation. There is a lot of vascular examination that goes with arterial imaging that we don't really do too often. So we are going to be learning about abdominal Dopplers again. We are going to be learning about how we can perform carotids, but we're also going to be learning how we can perform arterial legs. And then some of the little bit more involved vascular testing for the arterial system. So we'll learn about ABIs, that's short for ankle brachial index. We'll learn about segmental pressures, and those are all exams that we aren't seeing too often in the clinical environment, but are associated with the arterial system. And if you were to work in a vascular lab, you would be responsible for performing those exams. So just some basic anatomy here on this PowerPoint. This should all serve as a review. You should remember this from your A&P course, but just to kind of reiterate here, our arterial vessel is very similar to the veins. They are going to be made up of 3 layers. So we still have our tunica intima, media, and adventitia. Our intima, that's going to be that inner layer, smooth endothelial cells making up that innermost layer of this wall. Tunica media, that's going to be our thicker middle layer. This is made up of really thick elastic fibers. So this is going to be a very muscular layer. This is something that is responsible for the propulsion of the cardiac pulse. So this is why it's going to be a little bit thicker in an artery than it is in a vein. And then our tunica adventitia, the outer layer, like our veins, the outer layer of the artery is also going to have the vasa vasorum, those tiny little vessels that are going to bring oxygenated blood to the walls of that artery. And here is a cross section of what that artery will look like. You can see that tunica media really, really thick, especially in comparison to the tunica intima and the adventitia. So our microcirculation, so before we get into like the cardiac contraction, we have to have a broad understanding of what the arteries look like throughout the body. So very similar to the venous system, the further away from the heart we are, the smaller those arteries are going to be. So we have really proximal to the heart, we have our great arteries, right? These are going to be our standard arteries. Are typically going to be bigger in size as they're closer to our heart. And as those arteries travel further away from the heart, they become smaller and they turn into arterioles. Once those arterioles are starting to reach the destination of those distal tissues, it's going to communicate with those tissues and communicate with the venous system in the capillary beds. So from biggest to smallest, arteries to arterioles to capillaries. Now remember, we said our venous system is originating at the distal tissues. Our arterial system is ending at the distal tissues. So it's originating at the heart. Our arteries, these are going to be responsible for transporting gases, nutrients, all of those other big important essential substances. Like we said, the size of the arteries is going to be inversely related to the distance from the heart. So the further away from the heart they are, the smaller the size of the arteries. Our arterioles, something about these that's very important is that they are going to be high resistance vessels. So our arteries are high pressure vessels, right? They have that big cardiac pulse that they have to send out to reach all the way into the distal tissues. But the capillaries in those distal tissues are really small networks, right? It's a very like fine process in those capillaries. So the capillary beds, they can't accommodate the very high pressure from the arteries and from that cardiac contraction. So the arterioles kind of serve as like a rumble strip. So if you've ever seen like, I'm not like a big like NASCAR person, but, or like a car person by any means, but if you've seen people like speeding or traveling really fast in a car and then they hit a rumble strip, it slows them down significantly. So the arterioles are going to say, whoa, we need to slow all of this blood pressure down significantly in order to be able to effectively communicate with the capillaries. So it's kind of like, you know, that little like strip of highway that says, okay, you got to really slow down your speed here, or else, you know, we're going to have an accident. Something bad's going to happen. Okay, so the aortic arch, we're getting into a little bit of the pathway here. This is going to be the origination of our arterial system right after it comes out of our heart. So the arch itself is going to originate from the left ventricle of the heart. The left ventricle is how everything's getting out of the heart, and it's going to then become our ascending aorta. So it's traveling upward from that left ventricle, hence the term ascending aorta. It's then going to kind of loop around a little bit, and that's where we get the term arch. The first, we have 3 branches that are going to come off of that aortic arch. The first branch is going to be on the right side, and that's going to be our innominate or right brachiocephalic artery. We only have this on the right side. So from there, that innominate is going to divide into the right common carotid and the right subclavian artery. Our second branch off of the arch itself is going to be our left carotid, and then our third branch is going to be our left subclavian. So 2 out of the 3 branches from the aortic arch are going to be on the left side. The reason why we have an innominate on the right side and then that innominate splits into the carotid and the subclavian is because that is the first branch off of the arch. That is the first branch right off of that really strong pulse. So it's kind of, if you're thinking about speed, it's a lot safer to only have one larger pathway right off of that initial kind of speeding point than it is to have 2 smaller ones. So because the pressure is still really high coming out of that left ventricle, it's safer, and it kind of provides a little bit more space and time for that pressure to slow down a little bit if there's only one pathway. And then on the left side, it's kind of traveled for a little bit longer. You know, some of it's gone off into the right innominate. So on the left side, the pressure is slightly lower, so it's a little bit safer for us to have 2 branches coming right off of the aortic arch on that left. So here's what that's going to look like here. We would have our left ventricle right here from our heart. We have our ascending aorta. The coronary arteries, kind of like the vasa vasorum, these are going to supply the outer tissues of the heart. So right off of our left ventricle, we have our ascending aorta traveling upward. Our very first branch is going to be that right-sided innominate, which will split into our carotid and our subclavian. And then the second branch is going to be the left carotid, and then the third branch, left subclavian. So when we're doing carotids, we need to be aware of that anatomy and the difference between the right and left side. Okay, so traveling along, we're going to kind of follow that pathway a little bit, and we're going to kind of do the upper extremity arterial system first, and then we'll work our way down. So we said we have a subclavian on both sides. On the right side, we know it's going to come from the innominate, and on the left side, it's going to come from directly off that aortic arch. Both subclavians are going to turn into our axillary artery as they travel closer to our armpit, and then the arches above the clavicle are going to be above the top part of the lung, so the apex of the lung, yet posterior to some of those thoracic muscles, that anterior scalenus muscle. It's going to run laterally and inferior to the outer border of the first rib, and that's where it's going to become the axillary. And then before it becomes the axillary, the subclavian gives off 4 important branches. We typically are only evaluating the vertebral branch, but we will talk about the thyrocervical a little bit as we move through our anatomy, our arterial material this semester. So the 4 branches that are going to come off of the subclavian before it actually becomes the axillary are going to be the vertebral, thyrocervical, and the internal thoracic, as well as the costocervical. So subclavian is traveling horizontally along our clavicles. It's going to kind of do like this upward motion first. So the proximal portion of our subclavians, the arches are going to kind of go above our clavicle. And that's where it's going to travel anterior to the tippity top of our lung, the apex of our lung. And then as it continues to travel along the length of our clavicle, it's going to travel a little bit more posteriorly along those muscles. And then as it gets closer to our shoulders, it's going to start to run inferiorly. So it kind of does, although it travels horizontally, it kind of does like a little loop like that. So if this is our sternum here, and that's our clavicle here, Nah, I don't like that clavicle. Hold on. How do I erase? Here we go. And then this is going to kind of be our clavicle. So it kind of like pops over the clavicle to accommodate the top part of our lung, and then it dips down to become our axillary. Here is what that all looks like pieced together: aortic arch, right-sided brachiocephalic or innominate, splitting into the right carotid and the right subclavian. We see those 4 branches coming off that subclavian, and then towards our armpit, that subclavian is going to become our axillary. So our axillary artery itself, it's going to be a short segment. The axillary artery doesn't really travel that far of a distance, but in a very short period of time, it has 7 branches that are going to come off of it. And these branches are going to kind of go everywhere in that upper region. So you have to know these, especially for your vascular registry. You're going to have these branches coming off of the axillary that are the superior artery, thoracic artery, thoracoacromial, lateral thoracic, subscapular, anterior and posterior humeral artery, and the thoracodorsal artery. Each of those arteries are telling you where it's going to go. So the superior artery, that's going to the superior portion of the chest. The thoracic is traveling down and posterior a little bit to that thoracic cavity. Thoracoacromial, that is talking about the region of our clavicle near our shoulder. Lateral thoracic, again, lateral aspect of our thoracic cage. Subscapular, going right underneath that scapula region in our back. Humeral artery, the humerus is the upper part of our arm. That's the bone in our arm. So that one's traveling more into the anatomy of our arm. And then the thoracodorsal, that back midline portion of our thoracic cage. Our axillary artery is going to become our brachial artery once it has given off those 7 branches. And this is typically in the order that they're going to come off. So here, a little bit of a grainy picture, but here we can kind of see the relationship of the subclavian into the axillary. So the way that this is kind of laid out, here is where our axillary is starting. I don't like that that's red. Here is where our axillary is starting, even though it says axillary here. In reality, the axillary is going to kind of start a little bit like in this region. So this diagram is not super precise in relationship to like the skeletal structure of the diagram, but if we erase all of that, you can kind of see where those branches are coming off if you look really closely. So we have a branch here, a branch here, a branch here, and then we have here. And then we're going to see our axillary turning into our brachial right at that kind of upper junction of the armpit. You don't need to know necessarily the precise anatomy and supply of the branches of the axillary, but you need to know what those 7 branches are. You need to know that the axillary has 7 branches, and you need to know the names of those 7 branches. You don't need to know the fine details of each of those branches. Okay, so kind of following the axillary down, we said it's going to turn into our brachial artery at that upper portion of the arm, and it's going to terminate about 1 centimeter distal to our antecubital fossa. So the bend in our elbow, our antecubital fossa, about 1 centimeter below that into our forearm is where we're going to see that brachial artery end and then become our radial and ulnar arteries. So 1 radial and 1 ulnar will split off of the brachial at that location. So our radial and our ulnar, as we said, they're both going to originate from the brachial artery. The radial is going to travel down our forearm along the lateral aspect. So remember, if you're thinking about lateral and medial forearm, it's in reference to palms up. So if you imagine your palms upward, the medial aspect is going to be the sides of your forearms closest to your body, like to your, thorax and abdomen, and then the lateral aspects are going to be out towards your thumbs. So the radial artery is going to travel along the lateral aspect. It's going to kind of go towards that thumb region, and then once it reaches the hand, it's going to have a branch that comes off it that's going to go off and become the main portion of the superficial palmar arch. That is going to terminate in the deep palmar arch by joining with the branch that comes from the ulnar. So it's a little bit of a give and take relationship in terms of the superficial and the deep arches with the radial and the ulnar branches. So the ulnar artery, also coming from the brachial artery, is going to travel along the medial aspect of our forearm, so towards our pinkies. And then once it reaches the hand, a branch from that ulnar is going to come off and be the main portion of the deep palmar arch, and it's going to communicate with that superficial palmar arch where it technically terminates. So let's take a look at that a little bit further. So here we have our brachial artery dividing kind of right in that distal anticube fossa into our ulnar heading towards our pinky and our radial heading towards our thumb. Let's take a deeper look at the palmar arches. We have a better diagram on our next slide. So our superficial palmar arch, like we said, this is going to be composed of a main branch from the ulnar artery and from the radial artery, and then it's going to be in communication with a very distal portion branch of the ulnar artery. So this is going to be the predominant source of blood supply to the hand, and then our deep palmar arch is going to be that main branch off of the ulnar artery that communicates with the distal portion from that radial artery. Our digital arteries, these are going to be those small arteries that are coming from each finger, and it is going to have a lateral and a medial branch that is going to divide from each of those. So let's put that all together. So here we have our ulnar artery, like we said, traveling towards our pinky, radial artery traveling towards our thumb. I'm going to give the ulnar artery the color pink. So here we have our ulnar artery, and we have this branch that is going to sorry about that. I got a notification that my bandwidth was low. Okay, so I'm not sure what we had said. Hold on one second. I'm just going to erase this and start over. So we're going to start with our ulnar and our radial arteries. I'm going to give the color pink to our ulnar artery, and I'm going to give the color, let's say, green to our radial artery. So our radial artery, like we said, that's going to be the main source of the superficial palmar arch, and that is the main source of blood supply to the hand. So we're going to start with that one. So our radial artery is going to branch off to become our superficial palmar artery. So that's going to be this guy right here. So this is going to travel all the way around. We're going to kind of branch off into our digital arteries. We have a medial and a lateral, and then that is still going to continue on. Our superficial palmar arch is still going to continue on, and then as it gets to the other side of the hand, it is going to join with the distal portion of our ulnar artery. So our ulnar artery at the same time is kind of going like so, and it's going to become the main source of our deep palmar arch. So it's kind of going along the opposite surface of the hand, and it's joining with the radial artery that way. So we're having a connection between the radial and the ulnar arteries at basically both ends of the superficial and the deep palmar arch. It's kind of like a big loop-de-loop, and in that process, we're having blood supply branching off for those digital arteries. So as that ulnar artery was forming that deep palmar arch, we had blood supply going to those digital arteries as well. And then once those digital arteries got towards the fingers, kind of branched off into medial and lateral supply for the fingers. So it's a excuse me, it's a complex relationship between the palmar arches, but you're having kind of this full circle communication between the two branches that come off of, one, the radial artery, and two, the ulnar artery. Okay, so that was our upper extremity. Now we're going to kind of work that aortic arch downward. So we had our ascending aorta, like we said, that's going to go off and supply the upper extremities and the head. And then as we come down that aortic arch, we are then going to be transitioning into the descending thoracic aorta. So this is going to extend downward from the aortic arch into the superior region of the diaphragm. Now, our thoracic aorta is not something that we are typically evaluating in the regular ultrasound world, but a lot of echo exams do evaluate that thoracic aorta. We can't, our equipment isn't programmed to look through lung and look through rib spaces like that, whereas echo probes are manufactured a little bit differently, so they're able to evaluate the thoracic aorta a little bit more than we can. Once that thoracic aorta passes down through the diaphragm, that's where it's going to become the abdominal aorta, and this is really where we're starting to evaluate that lower half of the arterial system. So as we know, it's an extension of the thoracic aorta. It's going to contain major visceral branches. So these major visceral branches that are coming off of the aorta are going to be our celiac, our SMA, our renal arteries, and our IMA. Of course, there are going to be other smaller branches that come off of the abdominal aorta, but those main ones are going to be those four right there. Some of the additional ones, or some of the parietal branches that are going to go off and be sort of supporting branches from the aorta, are going to be the inferior phrenic, which are going to come off of the aorta within the abdominal cavity, but they're going to travel upward to supply the inferior border of the diaphragm. We also have our lumbar arteries, which are going to go and supply our lumbar region, and our middle sacral artery, which is going to supply the sacral region of our body. So here's piecing that all together. So we have our ascending aorta branching off into our aortic arch with the right sided innominate turning into right carotid and right vertebral, right subclavian. Second branch off the aortic arch, left carotid. Third branch is our left subclavian. Then we're coming down into our thoracic aorta. Once it passes through that diaphragm, it's going to become our abdominal aorta. We have those four major branches coming off of the aorta, which are our celiac axis, our SMA, our renal arteries, and our IMA. And we also have those supporting structures as well. So our phrenic arteries, our lumbar arteries, and our middle sacral artery. Once that abdominal aorta travels down and it gives rise to the IMA, it's going to split into our common iliac arteries, and each one will go down respectively to a leg. So let's talk about the abdominal branches first, and then we'll kind of get more into the leg anatomy of the arterial system. So the first major branch off of the abdominal aorta is going to be our celiac artery, also known as our celiac axis. This artery is going to have multiple branches that go off and supply a lot of different structures within the abdominal cavity. So it's going to branch into our left gastric, which is going to supply our stomach. It's also going to branch into our splenic artery and our common hepatic arteries. So overall, the celiac axis is responsible for supplying blood to the stomach, liver, pancreas, duodenum, and spleen. So a lot of responsibility coming off of that first branch of the aorta. Now, when we're looking at that, we're going to kind of see that at the region. If we're looking at it in sagittal, we're going to see it at the region of the left lobe of the liver, and we're going to see it coming off first. So here we have our proximal aorta, and then we have our celiac right there. Now, directly underneath that will be our SMA. So sometimes it's very easy to confuse the celiac with the SMA because you can sometimes see the SMA coming off right there. So you want to make sure that you're giving a good evaluation. So both of those, whatever one is coming off first, is going to be our celiac axis. Transverse is a little bit easier to tell because you're going to see those additional branches coming off of the celiac axis, and that's kind of what we give the seagull sign. We kind of term it the seagull sign coming off. So here we have our IVC, here we have our aorta, we have our celiac right here, and then this is going to be our common hepatic coming off, this is going to be our splenic coming off, and this little guy right here, can't really see him branching too much because of the way we're looking at it, but that's going to be our gastric. So that little branch is going to go off to supply our stomach. So our SMA, like we said, this is going to be the second major branch off of the abdominal aorta. Typically, it's going to come off about a centimeter distal to where the celiac axis does, but sometimes we can get that very confused because of how close they are to each other coming off the aorta. And in some patients, we can actually see a shared trunk. So not only is the celiac axis its own branch that has multiple branches, but sometimes the SMA can also be coming off of that same region or that same trunk. So we don't see that too often, but if you do see that, you just want to make sure that you're aware that that is a type of anomaly. The SMA itself is going to be responsible for more of our GI system supply. So more of our small intestine, the cecum portion of our intestine, the ascending colon, and the small portion of the transverse colon as well. So here we have proximal aorta, here we have celiac axis coming off, common hepatic coming off, splenic coming off that celiac axis, and then second branch right behind that celiac axis is going to be the SMA. Our renal arteries, that's going to be our next branch coming off of the abdominal aorta. We know these are going to supply our kidneys, but also our adrenal glands and our ureters. Very common to have a duplicate renal artery, and it's actually easier for us to identify the left renal artery than it is to identify the right. And that is because of the relationship and the position of where the IVC is. So typically our aorta is going to be on the left side of our body and the IVC is going to be on the right side of it. And the IVC usually sits in front of the aorta. So the right renal artery has to kind of loop around posteriorly that IVC to reach the right kidney. So the left kidney, we're not really having to look around the IVC as much, and it's actually going to be more anterior than the right one is. So left side's a little bit easier for us to identify than the right side. We can use the left renal vein to help us find the left renal artery, but usually we're not really having too much trouble identifying the left renal artery anyway. Left renal vein is going to cross the aorta anteriorly and superior to the left renal artery, and the right renal artery, like we said, has to travel posteriorly to the IVC. Right renal artery is usually going to be longer than the left renal artery, and the left renal vein is going to be longer than the right renal vein. And if you just look at our diagram here, this is our right, this is our left, this is our aorta, this is our IVC. So our left renal artery is shorter than our right renal artery, but our left renal vein is longer than our right renal vein. So it's a little bit confusing if you're just listening to the words that I'm saying, left renal, right renal, artery, vein. Like, it's a lot of words, but just look at the diagram. Look at how the IVC and the and the aorta are positioned with each other, and how those branches in terms of renal artery or renal vein are in relationship with each other. So just think about like basic distance, basic positioning. That should be able to piece that together for you guys. Next, we have our IMA. This is something that we aren't typically evaluating too often. There are certain exams where we can and are asked to evaluate the IMA, but it's very challenging for us just because of where it's located. It's located really behind a lot of bowel. So as we know, that makes our job a lot harder. But this is going to be responsible for supplying the rest of the GI system. So transverse colon, descending iliac, sigmoid, and rectum. It's going to come off of the aorta about 3 to 4 centimeters above where we're going to see that aorta bifurcate into the common iliacs. So very distal in that aortic region. And here's a nice little diagram kind of piecing those branches together with the GI system. And then next we have our common iliac arteries. Like we said, this is going to be our bifurcation, our aortic bifurcation. Each one is going to respectively go down each leg. So this is going to be the termination of the, these are technically terminal branches of the aorta. We do have a right and a left. Common iliac artery is going to be responsible for supplying the legs, but also the pelvis and the abdominal wall. Our common iliac is going to divide into two branches. The external iliac, which is going to travel down the leg, and the internal iliac, which is going to travel posteriorly and supply that pelvis and supply the abdominal wall. So we also call our internal iliac our hypogastric. We should remember that all the way back from our foundations course about where the hypogastric region was, and that kind of makes sense as to where these internal iliac branches are going to travel to. The division of these two, so the division of the common iliac into the internal and external, are going to occur at the level of the lumbosacral junction. So right at where our lumbar spine turns into our sacral portion is where we're going to see the branches. The internal iliac is obviously going to be a little bit smaller than the external because the external is still responsible for going off and supplying the entire leg, whereas the internal is just kind of supplying that local region of the abdomen and pelvis. So like we said, external iliac traveling down into the leg. So as it travels through the inguinal canal, it is going to be, I put on the slide to talk about the internal iliac first. So we said this one's going to be a little bit shorter, 3 to 4 centimeters in length, traveling posteriorly deep into the pelvis. It's going to be supplying the wall, the glutes, the thighs, the perineum. It does divide into anterior and posterior branches to be able to reach all of those tissues, but we don't typically evaluate the internal iliac branch as much as we do the external iliac branch. So our external iliac branch, like we said, traveling down into each respective leg. It's a continuation of that common iliac. It's larger than the internal, like we said. It's going to travel lateral and inferior in direction. So it's going to travel kind of towards the outside of the leg in reference to the vein. And it's going to travel distally down that leg. It does travel medial to the psoas muscle in the back. So the psoas muscle, if you remember from anatomy, if you have like a really jacked bodybuilder and you look at their lower back portion, they have like a triangular shaped muscle in their lower back, like right above their bottom, and that's going to be the psoas muscle. So it's going to travel medial to that. It does pass underneath the inguinal ligament, where it's then going to become the common femoral artery. Again, this is kind of going hand in hand with what we learned about for our venous system. So remember, those major veins have a paired artery. That's what we're going to be kind of talking about following up here. Common femoral, like we said, the extension of the external iliac down into the leg once it passes through the inguinal ligament. It's then going to divide into the superficial femoral artery, which we kind of just reference as the femoral artery, and then the profunda as well. So same thing, kind of keeping on that same anatomic process as the venous system. Similar here, that femoral artery is going to then become our popliteal artery. It's going to travel all the way through that pop fossa. It's going to be supplying the knee, the joint, the skin. It is going to travel distally, and it will divide into anterior tibial arteries and posterior tibial arteries as well. And then our anterior tibial artery, just like our anterior tibial veins, going to travel along that anterior aspect of the fibula, so the outer aspect of our calf. It will travel distally and then kind of come around in front of the ankle joints. A little bit different or a little bit more in depth than our venous system. Our ATA is responsible for a lot of supply to the foot. And we don't typically evaluate the foot in a venous exam, but we do evaluate the foot in an arterial exam. So this is really important in patients who have uncontrolled diabetes or have, occlusions of their arterial system. The toes are typically the first to go. We see a lot of amputees with diabetic patients. We see a lot of toe amputation, foot amputation, lower limb amputation, and it all originates at the toes. So we have to understand this anatomy beyond just the calf. So our ATA is going to travel along, like we said, the outer anterior aspect of our fibula, so the outside part of our calf, and it's going to kind of loop around into the front of our ankle. It's going to travel right along that top part of our foot, and then it's actually going to become our DPA, our dorsalis pedis artery. That artery is going to travel along the top part of our foot and then actually head to our first toe, our big toe. The DPA is going to branch into a first dorsal metatarsal artery and deep plantar arteries. So this DPA is responsible for kind of the origination of our plantar arches. The deep plantar artery is going to supply the base of our foot, the sole of our foot, and it's going to unite with a lateral artery to complete the plantar arch. So the lateral artery, we kind of didn't really, we haven't really mentioned it yet. I just want to make sure I didn't have it on one of the previous slides. We'll talk about that in a second. So like we said, our calves and our artery are going to be very similar to our veins, but a little bit more in depth. So we have our ATA, we have our PTAs, and then we also have our perineal arteries, just like the venous system. We have that tibio-perineal trunk. So this is going to be that branch off of the popliteal behind the leg. Very short segment, and then it's going to split off into our posterior tibial artery and our perineal arteries. So here we have, this diagram is like if we were looking along the back side of the patient. So we have our popliteal artery. Once it kind of is no longer in the adductor hiatus, we are going to see the anterior tibial artery come off and head towards the front. A little bit further down, we're going to see that tibioperineal trunk, and then we'll see the split of the PTA and the perineal artery. This diagram calls it the fibula artery. It's just another word for it. So our PTA, like we said, branch off the tibioperineal trunk. It's going to travel down the medial aspect of our calf, so kind of along the meat of our calf. It's going to travel inferior and, excuse me, kind of around the rounded part of the inside of our ankle. So that bone, if you are to feel the inside of your ankle and you feel that round kind of bone right at that junction of your foot, that is known as your medial malleolus. We have two malleoli in our feet. We have a lateral and a medial. The lateral one's going to be like that big round bone that sticks out on the outside part of your foot and your ankle. The medial one's going to be a little bit softer but still round on that aspect. So it's going to kind of do like a little loop-de-loop down along that medial malleolus. So here's going to be the medial malleolus, little bony projection, and it's going to travel down and deep. It's then going to divide into medial and lateral plantar arteries. Now here's that lateral plantar artery that we just said is going to communicate with the DPA. So here we have our lateral plantar artery. It's going to travel along the lateral aspect of the foot. We're going to kind of get into that plantar arch a little bit, and then here we have our medial plantar artery traveling along that medial side of the foot. So our perineal artery, like we said, also coming off the tibioperineal trunk, it's going to travel towards our fibula, so along the outside of the patient's calf, and it's going to travel downward along that region. So it's going to kind of be a little bit between the tibia and the fibula, so it's still going to be on the lateral aspect of the calf and the calcaneus region of the foot. And here we can kind of see, again, we're looking at the back side of the patient's leg. We see our popliteal, we see our anteriors coming off, tibioperineal trunk here, PTA coming off here, perineal coming off here, and kind of traveling along that medial aspect of the fibula, but still lateral in reference to where the PTA is. So that is going to travel down along the foot, along the outside of the lateral malleolus. And now we're going to kind of get into the relationship of the plantar arches. So a lot of that, like we said, is going to be coming from the DPA and then also the lateral plantar from the PTA. So comprised of the DPA. So, okay, let me kind of back up for a second here. We have our dorsalis pedis artery, and then we also have a deep plantar artery. Okay. DPA is dorsalis pedis artery, not deep plantar artery. Deep plantar artery, that's just how we reference it. DPA is dorsalis pedis artery, so two separate things. The deep plantar artery is going to be a branch from the DPA, but they're going to be two separate segments. So don't be confused by that acronym. Plantar arch, comprised of the deep plantar artery, which is a branch from the DPA, which came from the ATA, and the lateral plantar artery, which came from the PTA. Now, our dorsal metatarsal arteries are going to supply the digits, so kind of like the digital arteries. They're going to go down off into the toes. So here we have PTA coming down along medial malleolus, splitting into lateral plantar, which is going to head off to that lateral side, and medial plantar. That lateral plantar is going to kind of loop-de-loop around the foot. Meanwhile, our ATA is traveling down the front part of our foot, and once it kind of reaches where like our foot kind of flexes and extends, it's going to become our dorsalis pedis, or DPA. That DPA is going to, or DPA, that DPA is going to branch off into our deep plantar, and that is going to kind of finish off the loop to meet with that lateral plantar. And while that's all happening, from that loop, we are going to have blood supply coming off to go and supply the metatarsal arteries to go off to the toes. So the arches in both the hand and the foot are very complex, and that's kind of just keeping it very basic. So make sure you have a good understanding of that, and then we will move into our arterial hemodynamics.